The Genuine Article. Discussion and commentary based on articles from JACC.
Hello, I'm Tony DeMaria, the editor of JACC, here with the Genuine Article, and I'm sitting next to one of my good friends and colleagues here at UC San Diego, Alan Mizell, as a matter of fact, an associate editor of JACC. And Alan was the lead author on a huge multi-center trial that looked at the ability of some new biomarkers, specifically mid-region prohormones, pro-ANP and pro-adrenomedullin, in their ability to diagnose and prognosticate in patients with congestive heart failure. Alan, why do we need new biomarkers in heart failure? You've been responsible for showing that BNP and NT-pro work pretty well.
Those two markers do work well, but I think we can always improve. There are areas where the natriuretic peptides do fall a little bit short, such as in older patients, patients with renal dysfunction, patients with obesity, and this gray zone. So there are new markers around, and the mid-region markers take some markers that we know are valuable, but we can't really measure in their native form, like AMP, arginine vasopressin, adrenomedullin. So we take now the mid-region prohormone fragment, which is a very stable in vitro and ex vitro, make a sandwich immunoassay, and they work very well to study patients.
Okay, so this was a very large study that you undertook to document the role of these new prohormones. Tell us a little bit about the study design.
Sure. This was over 1,600 patients, 15 centers around the world. Physicians in the emergency room were blinded to the biomarkers we were looking at. They could use BNP and NT-pro if they had that available at their institution. We had adjudicated diagnoses and follow-up of 90 days for cardiovascular and all-cause mortality.
And as I recall, it was a non-inferiority type of analysis.
Non-inferiority for the diagnostic aspect for AMP, and the prognostic, it was superiority of ADM over BNP and NT-pro.
Okay, well, how do these new prohormones stack up then?
Well, they stack up very well. The AMP, mid-regional AMP, did just as good as BNP and NT-pro. In fact, if you take out the patients from the analysis who didn't have any NT-pro and BNP in their ERs, the RLC curves were exactly the same. In areas such as obesity, age, gray zone, and renal dysfunction, natriuretic AMP actually added value to the natriuretic peptides. Now, for ADM, adrenomedullin, mid-region adrenomedullin, was more prognostic than B and NT-pro BNP. If you had adrenomedullin in any multivariate analysis, you could throw out BNP and NT-pro. The reverse was not true. If you threw troponin in there, BNP, NT-pro would fall right out, but adrenomedullin was certainly still extremely vigorous as a prognostic marker.
So as we go forward in the future, do you see the natriuretic peptides being displaced by these new prohormones, or how are we going to apply these new agents?
I think we'll look for areas where they can work together, especially where the natriuretic peptides fall short. I believe in the future we will use multi-marker panels where we'll probably use some natriuretic peptides, we'll use troponin, we may use a renal marker, and probably some of these mid-region markers will come up as being valuable alongside our standard bearer, one of the natriuretic peptides.
Well, there's no question that the biomarker field is expanding rapidly, using it not just for diagnosis and prognosis, but perhaps even as surrogate endpoints and maybe in the future to really guide our therapy. We'll follow your work closely. For the Genuine Article, I'm Tony DeMaria.
The Genuine Article. Discussion and commentary based on articles from JACC.